Grab a coffee, δεν έχουμε διάλειμμα, οπότε θα συνεχίσουμε αμέσως για την τελευταία συνεδρία, last but not least. Δεν ξέρω αν έχει συνδεθεί ο κύριος Καραμιχάλης. Ωραιότατα. Οκ, οπότε θα ξεκινήσουμε. Καλώς το Γιάννη. Άλλος ένας Κύπριος καρδιοχειρουργός, ο οποίος κάνει καριέρα, γεια σου Γιάννη, κάνει καριέρα στις Ηνωμένες Πολιτείες. Ο κύριος Καραμιχάλης είναι παιδοκαρδιοχειρουργός, με μεγάλη εμπειρία. Είπαμε εχθές ότι σήμερα θα ασχοληθούμε με το καρδιακό ήπαρ, γιατί θεωρούμε ότι χρειάζεται να το βάλουμε στην διερεύνησή μας ρουτίνα στους καρδιολογικούς ασθενείς και παιδιά και ενήλικες. Και θα ξεκινήσουμε με τον κύριο Καραμιχάλη να μας πει για το καρδιακό ήπαρ όσον αφορά ενήλικες με συγγενείς καρδιοπάθειες. Παρακαλώ, Γιάννη.
So, thank you for the opportunity to present today. I'm going to talk about adult congenital cardiac associated liver disease. I work at Columbia as a pediatric heart surgeon. So, I have no disclosures. So the agenda today, I'm going to talk about pathophysiology of a cardiac liver disease and the types of congenital heart disease and liver disease. We'll go through some liver changes after the atrial switch and Fontan-associated liver disease, the impact of Fontan-associated liver disease on the Fontan population, future directions, and evaluation of patients with Fontan-associated liver disease. So, as we know, the survival of adults with congenital heart disease increased profoundly recently. This is secondary to surgical or interventional techniques and stringent cardiological surveillance. New potentially underestimated non-cardiac health problems is apparent in congenital heart disease. Liver dysfunction is up to 6% in congenital heart disease patients that died in one of the studies. And in patients less than 25 years of age, cirrhosis appears about 11 to 15 years after the Fontan. So surveillance of non-cardiac issues, and especially liver, is highly recommended. The management of liver disease in congenital heart disease involves multidisciplinary approach with special attention to the pathophysiology and etiologies of liver dysfunction. The management includes the assessment, portal hypertension, management, surveillance, and management of hepatocellular carcinoma. We'll also touch upon the Fontan-associated liver disease single ventricle management as well. The causes of liver impairment in congenital heart disease includes liver congestion, hypoxemia, low cardiac output, and other issues, other causes. The pathophysiological alterations of liver physiology in congenital heart disease are mainly related to hemodynamic derangements, either from backward failure of the subpulmonary ventricle or venous congestion, or from forward failure of the systemic ventricle. It also involves hypoxemia in cyanotic congenital heart disease. Just reviewing the architecture of the liver assignments and its metabolic zones. Zone 3 is the most vulnerable zone, and you can see from the diagram here, this is divided into zone 1, 2, and 3. The portal triad is shown up here, and zone 3 is in the center, close to the central vein. And hemodynamic alterations, especially venous congestion, cause damage to the zone 3 and fibrosis, so that leads to cirrhosis. And mainly the venous congestion or the backward failure of the subpulmonary ventricle is responsible for sinusoidal dilation and hemorrhagic necrosis of zone 3. That leads to cardiac fibrosis and cirrhosis. and you can get post-hepatic portal hypertension, which is an important pathomechanism. Oxygen supply also is affected by the congenital heart disease, and that may be secondary to low cardiac output or cyanosis, and also impair oxygenation from lung issues that you see in congenital heart disease. Impaired oxygen supply, especially in the presence of venous congestion and sinusoidal dilatation, results in reduced portal inflow, reduced flow from the hepatic artery, and that gives you chronic hepatic ischemia. The type of congenital heart disease and liver disease, we're going through right heart failure is one cause, but also well known is baffle stenosis post-atrial, such as Muster or Senning in DTGA. Excuse me a second. Hello, can you leave it outside, please? Thank you. Also, Fontan in single ventricle palliation. Moving down, liver vein congestion is secondary to congenital or acquired tricuspid valve disease, such as tricuspid insufficiency, stenosis, decompensated pulmonary stenosis or pulmonary insufficiency, ASD or Epstein's, tetralogy of Fallot with pulmonary insufficiency, also cor pulmonale with pulmonary hypertension. Cyanotic congenital heart disease leads to hypoxemia and liver damage, as mentioned earlier. And this is a main concern in uncorrected cyanotic lesions, such as tetralogy of Fallot, DTGA, truncus, TAPDR. You can also get secondary cyanosis from left to right shunts that reverse and getting a shunt inversion or right to left shunt, such as Eisenmenger syndrome. And hypoxemia would lead to hepatocyte necrosis and alteration of liver structure. Reduced cardiac output, which is secondary to forward failure of the RV or LV, leads to decreased arterial blood supply, and severe LV failure may progress to backward RV failure. You can also have primary morphologic RV failure, and also other medical issues affecting the liver can be part of this. So I want to review first the atrial switch or Muster or Senning in DTGA. That's nowadays you see less and less unless you're in developing world. But you can see schematically the baffles that are part of this operation, but more commonly you get stenosis, especially of the inferior systemic venous baffle, the veno-atrial junction, and also you can get through fibrosis or reendothelialization of the atrium. The obstructions can be complete or incomplete and may be associated with pulmonary venous obstruction too. Liver changes take place if you do get those obstructions in atrial switch patients, and the clinical signs will include ascites, lower extremity edema, liver enlargement, and protein losing enteropathy. The pathophysiology includes liver fibrosis or cirrhosis that could be obvious on transient elastography or acoustic radiation force impulse imaging. Moving on to the post-Fontan liver changes, that's so much common nowadays, especially in the developed world. Most commonly, you can see liver fibrosis, cirrhosis, and need to be well aware of hepatocellular carcinoma that can develop, portal hypertension, protein losing enteropathy. Just reviewing briefly, single ventricle congenital heart disease involves complex forms of lesions in the heart that ends up being a one ventricle repair. This was previously universally theta, but since 1968, the development of Fontan operation that was further was developed in a better way and improved survival dramatically. This is schematic representation of the fontan. The first diagram here shows atriopulmonary connection. That was the original fontan. On the second one, you can see extracardiac conduit fontan with or without fenestration. Also, the third one is the lateral tunnel. That's less commonly used these days. We have approximately 70,000 individuals or more with fontan worldwide, and the population is predicted to double of these patients in the next couple of decades. Fontan comorbidities could cause issues from a physical, psychological, and neurodevelopmental well-being, and this involves a complex pathophysiology issues that result in multi-system disease and fontan-associated liver disease. Dissonance between degree of morphologic abnormalities and liver functional status exists. Imaging or liver pathology may not predict clinical outcomes. That's where the trick comes in. It's unclear how to define hepatic reserve, and it may impact cardiac and non-cardiac surgery. It may impact transplant outcomes. The risk of hepatocellular carcinoma or decompensated liver cirrhosis is known, and we don't know who is at the highest risk. This is a slide on hepatocellular carcinoma in fontan-associated liver disease. We definitely see increased rates in the fontan population. The factors associated with hepatocellular carcinoma risk still are poorly defined, and fontan-associated liver malignancies are associated with dismal survival, as shown here on the right in the diagram. There's poor correlation between standard serological metrics of hepatic dysfunction and prognosis. There's also absence of established biomarkers associated with poor clinical outcomes, and there's absence of established imaging biomarkers that correlate with clinical outcomes. So there's still a lot of things in the future to be developed. What we do know is there's no known association between pathologic fibrosis grade on liver biopsy and mortality in the fontan population. And we'll come back to this later. Pathologic metrics of liver fibrosis do not accurately capture patient risk either. And an expanded approach to delineate the underlying cellular mechanisms of fontan-associated liver disease is needed to improve outcomes and prognosis. The mechanism of liver disease in fontan patients is multifactorial and primarily involves elevated venous pressure, background pressure, lymphatic congestion, arterialization of hepatic blood flow. And this is a schematic representation of the different causes that are involved in liver injury. We mentioned hemodynamic changes. There is perioperative liver injury at the time of surgery, and there are additional factors such as hepatotoxins, lipopolysaccharides, viruses, and other potentiating factors, including TGF-beta release, and this is mechanism transduction schematic representation here of the injury leading to fibrosis and cirrhosis. You can see here on this picture, zone 1, 2, and 3. Zone 3, as mentioned earlier, is the most vulnerable, and that's affected by congestion and also by ischemia. You get mechanical tension, hyperfiltration, edema, and in addition to the venous congestion from increased venous backflow pressures, leading to fibrosis and cirrhosis. The mechanism of injury, as mentioned, involves high pressure of the sinusoids from chronic congestion, hypoxic injury, and inflammation. Cellular injury includes damage to zone 3, and this could be from ischemia and congestion. The endothelium gets dysfunctional, especially this is seen in Fontan population, and there are other factors, stellate cell activation and other immunological issues. As you can tell from this slide here, this migration of immune cells that also play a role in the pathophysiology. Congestive as a primary driver of liver disease, the mechanical stretch of sinusoidal cells may promote thrombosis and cause endothelial dysfunction and damage. It also activates stellate cells and accumulation of other things like hyaluron. Endothelium is very closely associated with the pathophysiology, and other factors as shown here are involved. Moving on to hepatocellular carcinoma, phenotypically may be more similar to cholangiocarcinoma, and is not always a consequence of cirrhosis. The survival is dismal. There are tumor markers that can be involved, including AFP, and imaging tumor staging is part of the assessment management. Looking a little bit more into the future, we need to build collaborative models across adult and pediatric cardiology and hepatology. The application of omics is important, looking for biomarkers for screening, multiplex immunohistochemistry, immunofluorescence. This is in the planning phase. Single-cell RNA sequencing, and utility of ISPC models. I just want to talk a little bit about the surveillance of Fontan-associated liver disease. Patients post-Fontan with no clinical evidence of chronic liver disease, they get at 10 years surveillance liver biopsy, and this should be done during cardiac catheterization, usually. If there's no fibrosis, then there's surveillance still ongoing, but less stringent. If there's fibrosis or liver dysfunction and heart failure, then obviously the surveillance becomes more frequent, and different tests are shown here. Patients are more than 3 years after Fontan, but they have signs of ascites, splenomegaly, thrombocytopenia, GI bleeding, jaundice. They get hepatology referral earlier and should undergo liver biopsy and a bunch of other tests. At Columbia, we have a protocol for following these patients as depicted here. This is kind of a busy slide, but essentially it's says the same thing my earlier slide said. I just want to touch a little bit about liver transplantation, Fontan-associated liver disease. Something that we more and more commonly discuss nowadays, especially here at Columbia with our liver combined heart transplant program. But you can see that pre and post isolated heart transplantation, there are certain laboratory tests that include the presence of ascites, varices, splenomegaly as under the VAST score. These patients routinely get liver MRI scores and liver biopsies. There's a model for end-stage liver disease MELT. But the conclusions in this paper is that liver MRI and VAST scores improve post-transplantation, but post-transplantation liver biopsy scores did not change significantly. Therefore, pre-transplantation liver biopsy demonstrating fibrosis alone should not exclude consideration of isolated heart transplantation. So this is very relevant when we discuss patients whether they should get a combined liver heart transplant or just heart transplant alone. This is one of my last slides on transplantation considerations for patients after Fontan. You can go the heart transplant alone pathway, or you can use combined heart-liver transplant. As mentioned in my earlier slides, it's difficult to predict whether heart transplant alone would be sufficient, or is it necessary to just do the combined heart-liver transplant. Thank you very much for your attention. I'd like to acknowledge our team at Columbia